All right. Well, it's 6:32, so we're starting to develop I think a full group here, and so we can go ahead and get started. So, welcome, Dr. Pauly. We're so pleased to have you here about a super important topic that I think is, depending on your training background, somewhat of a black box or something that a lot of us don't have a ton of knowledge about. Um, I know you and Dr. Eastlack go back, and so I was hoping he could say a few words of introduction. And Bob, I'm just going to turn it over to you.
All right. Well, if any of you have journal clubs or do even some cursory literature review, you'll recognize Dr. Pauly's name. He is a real special person in our field. His biomedical engineering mind lends a special perspective that I think we all benefit from in the way he analyzes problems. And one of those areas of expertise that he's world renowned in is the SI joint, something that we sort of uh, looked over, glossed over for decades. And Dave's expertise in that realm biomechanically, with his biomechanical engineering background, and then through even economical analysis, has really gotten us so much farther along in understanding the disease of the joint, how to treat it, and where we will benefit from it. We're very happy to have you, Dr. Pauly, and thanks for being with us today.
Well, thanks, Bob. And let's see if I can successfully share my screen here. So, are you guys seeing that all right now?
Yep, looks
We
good,
are.
Polly.
Great. Okay. So I did see that Beirut was on this morning, and so it's nice to connect with longtime friends and colleagues. All right, my disclosures, some of which are significantly relevant. My primary disclosure is that I've had to take care of this problem for a long time, and the way I was trained to take care of it in my fellowship didn't work for me. And so it's been a journey to try to do better. So I like the concept of bottom line up front. So uh, the SI joint moves a little bit. It is innervated. With physical exam maneuvers, we can stress the joint and recreate the pain. Image-guided injections can relieve the pain. There's limited data on the efficacy of non-operative treatment, and there's further emerging data on the efficacy of surgery. So is this a hot topic? Well, how do we decide if something's a hot topic? Interesting question. So we start with a PubMed search. So 7,000 articles for the SI joint, and for SI joint fusion, about 650. How many FDA approved devices? Somewhere around 36. So that indicates the industry interest in the topic. So is it a problem? Well, we all know that low back pain has a high burden of disease. I like to ask my residents, what's the number one reason people go to the doctor? And everybody says low back pain. No, it's not. It's actually URIs. What's the number two reason people go to the doctor? Low back pain. And turns out the SI joint accounts for probably 15 to 30% of low back pain, and it is very debilitating. Non-operative care is expensive because it's recurring care and has low levels of evidence for its benefit. However, it's also low risk. So how often is low back pain coming from the SI joint? Well, the data ranges from 15 to 30%. However, if you've had a lumbar fusion, that goes up from to 30 to 43%. So how did I really get started in this space? So when Jonathan Sembrano was my research fellow, he's been my partner for a number of years now. We looked at 200 consecutive patients who were referred for back pain. None of them had had surgery on their spine, hip, or SI joint. And this is what we ended up with in terms of final diagnosis. And so it turns out that there is a fair bit of SI joint pain in people referred for low back pain. And some lucky people had all three of these. So the differential diagnosis of low back pain is challenging. It's really applied anatomy for all the structures in the area. And I just love this slide from Dr. Baronio in Italy. And I think we need to add some things to it down the road. But it's sort of like if there is a structure in this area and it's innervated, we need to include it in the differential diagnosis. How disabling is low back pain? Well, every condition on the planet can be rated in a scale of 1.0 of perfect health to 0 of death. And that all of these conditions have been rated, and this is a standard medical economic strategy to look at burden of disease. And it turns out that the patients enrolled in the SI joint surgery trials were at a 0.5 quality adjusted life year score, which is pretty darn disabling. When we compare it to other conditions that we might be more familiar with, it's actually similar to people who need total hips, surgery for lumbar stenosis, degen spondy, etc. How much does it move? Well, there have been a series of challenging studies trying to figure out how do we judge this. And so the bottom line answer is it flexes or extends 1 to 2 degrees. In lateral bending, there's maybe a little bit more and a little bit in axial rotation. How does it work? Well, there's something called form and force closure. So the form part of it is sort of a keystone arch, and the force closure part of it is the muscle in the area compressing across it, and that combination gives us the stability. Sorry, my PowerPoint froze. There we go. So Bengt Sturesen from Ängelholm, Sweden, originally got us really smarter about this. He did the RSA studies on it, and he had a number of women with postpartum inability to walk because of their pelvic pain from delivering. And so he put X fixes on them, and it took away their pain, and they were able to walk normally. And how did that work? Well, it helped with the force closure of the joint and allowing them to then function. How much load goes across the SI joint? This is what I can find in the literature, but I actually think it's substantially higher than this, especially in people with flat back syndrome who are way out in positive sagittal balance. How is it innervated? So I absolutely love this slide. So Hilton's law, and it's not that if I stayed at a Hilton last night, I'm going to do great today. It's that any nerve that crosses a joint can innervate that joint. So the possibility of innervation of the SI joint is actually quite profound. So what do we know about the SI joint innervation itself? Well, there have been some wonderful histologic studies identifying nociceptive and mechanoreceptors within the joint, and they've been identified from both the dorsal rami and then Carolina Sasdak from the Netherlands, her PhD thesis looked at it in the front, and so she dissected out the joint capsule, dissected out the nerves going from the lumbosacral trunks into the anterior capsule, then did microhistology within the capsule showing substance P or nociceptive nerve fibers, and then found mechanoreceptors within the joint, and then CGRP is another pain sensing nerve fiber. And so these were all pain fibers within the capsule. And then she also looked at the sacral and the iliac sides of the joint and found the same nociceptive fibers. So absolutely, we have a pathway to transmit nociceptive sensation from the joint. So what does the basic science tell us? Well, it moves a little bit, it's innervated, and so now how can we make this diagnosis? This is absolutely the key component here. With these physical exam maneuvers, we can have high reliability that we can diagnose SI joint pain. So all of these exam maneuvers apply torsional load to the SI joint, hence trying to provoke it. So pelvic gapping, pelvic compression. And what I tell patients is I palpate the posterior hip capsule and I say, this is number one, and I palpate the PSIS and say, this is number two. Does it hurt number one or number two? And not where my hands are, but number one or number two. So gapping, compression, and this is about 40 pounds of pressure. Patrick's or Faber's test, thigh thrust, again, about 20 to 40 pounds of pressure. Sacral thrust, probably the least reliable, and then Gainsland's, which can either be done this way, or my preference is to do it side lying. So when we put these together, if you have 3 or more positive physical exam findings, there's an 85% positive predictive value that the patient will respond to an image-guided diagnostic injection. So this is actually one of the very best rules for physical exam diagnosis that we have in the spine. How about imaging? Well, imaging isn't that helpful for symptomatic patients. Plain films, CT scans, there are a lot of definable changes, and that there is an emerging thought and some publications that I worked with the folks from Mayo Clinic on, that if there is a vacuum sign within the SI joint, that's a sign of hypermobility and potentially helpful in making the diagnosis. MRI, we usually use it to rule out other things. It's very good for spondyloarthropathies, but not for garden variety SI joint pain. Bone scans, some folks have been enthusiastic about it, and I've tried to dig through the literature, and there's not really great stuff on this, including even the spec studies. So some people choose to use it. The challenge is that most bone scan reference for increased activity is based on the posterior superior iliac spine. So it's hard to know what is, quote, increased. If you see side-to-side differences, maybe that's helpful. So basically, imaging isn't that great to help us figure out what's going on. It can rule out some other things, but it doesn't rule in mechanical SI joint pain. So how about blocks? So one of the challenges that you have to be in the joint in order to have the block be effective, and that only 22% of, quote, blind SI injections actually went into the joint. And then we argue about how much pain relief constitutes a positive value. And that my approach is that I want to look at intra-articular structures, pain relief, not periarticular structures. So fluoro shots of what perhaps an optimal needle placement might look like. And then if I have any doubt, I prefer CT-guided diagnostic injections. Why? I have 100% certainty that the needle is in the SI joint when they do it this way. So what level of response constitutes appropriate a positive injection? So I got mad at NASS because they said, oh, it's got to be 75%. And it's like, where did that come from? The two randomized trials used 50%. And they said, well, we talked to our pain doctors, and our pain doctor said it has to be 75%. And it's like, okay. So what I did was I took the positive responses in patients in the clinical trial who responded to surgery and then looked at 50 to 75% versus 75 to 100% relief. And the bottom line is it didn't show a difference. So that 50% is probably as good as 100% pain relief. I mean, we feel better if the patient says, oh my gosh, but there's not data to support that it should be a 75% pain relief. So it doesn't tell us about patients who have a negative physical exam or patients who have less than a 50% response to injection in terms of how they might respond to surgery. So what are the surgical approaches? The most common and most reported one is the lateral approach. Then there is a posterolateral approach, and then a posterior intra-articular approach. And so these are the three ones that are commonly talked about today for the more minimally invasive type strategies, as opposed to the older conventional open ones. So what's the data? So the most data is on triangular titanium rods from a lateral approach. So these are prospective studies. They happen to be industry sponsored. So as a caveat, Insight was the US RCT, IMEA, the European one, Sci-Fi prospective cohort, Lois long-term follow-up, Sally follow-up evaluation on 3D printed implants. So the Insight trial, for which we were a part of, randomized 2-to-1 operative versus non-operative standard indications, and we looked at the primary outcome variables were visual analog pain scales and Oswestry Disability Index. Now, this study was conducted after this device was already approved, and so getting people to agree to randomization was a little bit of a challenge. So we said, if at 6 months you're not better, we'll let you cross over. And those who crossed over from non-surgical to surgical management had exactly the same response pattern as those who were randomized to surgery in the first place. And so basically, they got better by about 3 months and then maintained that out through the 2-year follow-up period. This was not originally a part of the clinical trial design, and this was like 2012, so it was before we were really so focused on opioids, and it did show a decrease in opioid use, but they were still opioid utilization. Very low adverse event rate due to the implants, one implant malposition, and then one fracture that was treated non-operatively. The IMEA trial, so this was the European trial. This was now a little bit better clinical trial design, one-to-one randomization, also looked at a couple of additional things other than just ODI and VAS. They also looked at EQ5D, which is a health-related quality of life tool to look at quality-adjusted life years. They also looked at ambulatory distance and some other things. So one-to-one randomization, the response pattern looks exactly the same, and that the 2-year responses all were pretty much parallel, and that they objectively looked at the people's ability to walk more than 500 meters, and that this improved compared to the preoperative status. Sci-fi. So in the insurance approval process, one company, Cigna, said, we're not giving you approval for this device until you have 5-year outcomes data. And we were like, where did that come from? And they said, well, that's the deal. I'm sorry, Sci-fi was we'll go do Sci-fi first. Prospective cohort study, open label, same pattern. And then when we pool these data from these 3 trials, they're all essentially equivalent in effect size, direction, and duration. Now, the pooled analysis, again, we looked at smokers versus non-smokers. Smokers improved, not quite as much as they started off a little worse and stayed a little bit worse compared to those who were non-smokers, and opioid users, similar modest decrease, but still clinically important changes. So I'm sorry, now the lowest study, 5-year follow-up of prospectively enrolled patients, and it showed durability of the intervention out to 5 years. Looking at opioid reduction, there was opioid reduction, but not necessarily elimination. Sally, so new new implant design came out, 3D printed, and basically follows the same pattern. And there was some question about maybe they got a little bit better, a little bit faster, but I would say essentially they're equivalent. And so here's a scan showing a 3D printed implant versus the original first generation implant. In Spain, Vicente Vanaclocha had patients who presented to him, and based upon their insurance status, they could either have to have conservative management, SI joint fusion, or radiofrequency ablation, and he had up to 6-year follow-up on his cohort. So what he found was that non-operative management did not make them better. Radiofrequency ablation made them better, but then they regressed back to the starting point, and that the SI fusion patients got better and stayed better out to 6 years. And same thing for VAS and oswestry. And in terms of working, more of the patients were working after surgical treatment than before. They had a much greater opioid reduction, probably a European versus a US bias. And so I think that is something that we're sort of making progress towards, but not quite there yet. How about revisions? So no operation is perfect, and that there is a revision rate, and that when the device first came out, the revision rate was higher, probably because of implant malposition, and that's gradually improved. The latest data that we have says it's about a 1% 1-year revision rate. How about cost effectiveness? Well, turns out if you look at how much does the intervention cost versus how much improvement does it make on the health-related quality of life issues, it's equivalent to total hip and total knee replacement, basically. And so those are considered very good healthcare buys in terms of being cost effective. Sorry, there we go. There are some devices other than the triangular titanium rods, a little bit less data, but similar kind of response effect. And so here's a interbody cage done, or interbody type cage done in a posterior interpositional strategy. And then here's the study on that. And then this is a bigger screw, different strategy, decorticate the joint and put this screw across, and that potentially works as well. So we recently did a systematic review of the published data on this. And so the background was, same kind of problem. What's the evidence look like? Here's the publication citation and the standard literature search, and looked at those where we had oswestry scores and potentially VAS scores. Also look for complications, the 3 different approaches, and then here are the various devices and the various approaches. And not all studies reported all outcomes, not surprisingly, and that this then is the meta-analysis of the top one being the lateral. So this had the greatest data support, and you can see VAS went from 8 to about 3, and then for posterolaterals and posterior interpositionals, not quite as good, but still significant improvement. In terms of pain scores or ODI scores, generally we see about a 50% improvement in the ODI, so from about 55 to about 35. And then perioperative complications, there are some that occur, and that how to dig this out is a little bit tougher. So large number of cohorts, most are retrospective, and that show consistent improvement with low complication rates. So biomechanically, how do we understand this a little bit? So when we fuse L5-S1, we increase the motion at the SI joint by 50%. When we fuse L4 to S1, we increase the motion on the SI joint by 168%. Conversely, when we fuse the SI joint, it's about a 2 to 4% increased motion on the lumbar spine and perhaps a 5% increased stress on the hip joint. So what do we do for patients who don't meet these criteria? Don't really know. A common finding for me is I get a lot of patients referred who have flat back and are fused to the sacrum and have SI joint pain, and someone gets an injection and says, oh, it's just your SI joint. Well, if you don't fix the sagittal imbalance, you're not going to solve the SI pain. Internal bony architecture is critical to understand, that you got to get into the S1 body to really get good bone. The ala is vacuous, and so that we've looked at this with one of Greg and Bob's former fellows, one of my former residents, looked at it and compared the density, and we were able to understand the density of the bone compared to L1 opportunistic bone mineral density. So what does the surgery look like? So representative radiographic example, diagnostic injection and response. I do these navigated, so I put a perk pin in the contralateral posterior ilium, navigate a K-wire into the upper portion of the S1 segment, put the implant in. I like trying to converge the implants a little bit. I think biomechanically that's a little bit better. And then the third implant, check images, and then we do a check spin because I don't want to leave the OR and ever have to bring somebody back. So we make sure our implants are where we want them to be. Takes about 45 minutes, blood loss about 25 cc's. I use local anesthetic. My institution won't let me use liposomal bupivacaine. Ice postoperatively is critical. I put them on protected weight bearing for 3 weeks until the gluteus medius recovers and they can stand single limb stance without a Trendelenburg, and then go from there. And so that's what that looks like. And why don't I stop at this point to do questions, Hani or Bob?
Awesome, Dr. Pauly. Thank you. Well, I'll open it up to the quorum here. Does anybody have any questions for Dr. Pauly?
Dave, John Hurlbert from University of Arizona. Thank you for that talk. I have a couple of questions, if that's okay.
Please.
First, when you are involved in T10 to pelvis or even higher, do you automatically fuse SI joint? And then the second question is, how often are you fusing just a single side rather than both sides?
Good questions, John. not surprised at all that you would ask good questions. So, in terms of fusing to the pelvis now, so if I'm going T10 to pelvis, Bob's study from ISSG showed about a 24% failure rate. And so I like to use the analogy of if you build a bridge with 2x4s, then it can handle maybe 80% of the load going across it.
How are you?
If you build a bridge with 4x4s, then it can handle a lot more. And so sort of
That's a little bit more.
which bridge would you rather go across? And so I would rather go across the one with 4x4. So my bias now is I do stacked SAI fixation bilaterally with bioingrowth implants and 4 rods to the pelvis. And with that, I've not had any mechanical failures, but I have had to remove one for a late infection. And then your other question about how often unilateral versus bilateral, about a third of the patients end up needing bilateral. It's amazing to me how many patients I'm seeing positive Baton signs and the clinical diagnosis of Ehlers-Danlos and having SI joint pain. And that I think they're probably predisposed to having bilateral problems, but their clinical response seems similar to people without Ehlers-Danlos.
Hey, Dave, Jamie Bruffy here from Scripps, Bob's partner. I do these here. Do you have a preference? Obviously, you're still putting in the trabecular metal triangles. Is that your preferred device at this point, based on biomechanical data and the studies that are available?
Yeah, so that's what has the best data are the triangles. However, I've moved more to the bioingrowth screw design form. And full disclosure, I'm part of the design team on that. And that the question of impaction versus non-impaction, that what I've found in general is orthopedic surgeons don't mind impacting things because we grew up putting in nails or whatever, or hips. And then my neurosurgery colleagues don't like slamming things into bone. They prefer screwing things into bone. And that the screw-in devices seem to work a little bit, it's a little bit faster, and that I've been happy with the outcomes. Don't have compelling data to tell you that one is better than the other yet.
Okay. And then I'll make another point. I do mine under navigation as well. And I think it's easier to place the screw-based device under navigation with better control and accuracy, following your path rather than trying to impact. Just with the tool set we have available, I think it's easier to do, technically easier.
I've not seen a difference. So I put in primaries about 1,000 implants. I had one that I broached a neuroforamen on that I had to back up.
Right. Thanks.
It looks like we have a question from David Oyang from Colorado. David?
Dr. Pauly, thanks for the talk.
Hey, Dave.
Question I have is in patients who have symptomatic SI joints who you also deem are hypermobile, what is your strategy in terms of positioning, knowing that there can be up to 7 degrees of motion?
Yeah, really great question. So a common question from the patients are that, hey, my chiropractor, physical therapist, manual medicine practitioner puts my SI joint back in place. And if you fuse it in the wrong places, it's still going to hurt. Bottom line is we don't have data to support or refute that statement. So what I do is I see if their manual medicine practitioner will come with them to the pre-op holding area and put their joint in place prior to going back to the OR, and then I just position them the same. But you know how we position on the table, that I pretty much catch every patient and put them on a 4-poster frame, and don't think that there's a lot of trauma associated with that. But I don't have a different answer on that, David. And it's a good question, and I'm not quite sure how we can effectively study it.
Dr. Akbarnia?
Hi, Dave. Thank you so much. I'm in DC with the POSNA meeting, and I took off to listen to your great information. Thank you so much. My question is a theoretical question. If do you think that fusing the SI joint would have any effect on developing or accelerating changes in the degenerative changes in the hips and knees, I mean, the lower extremities?
So I love that question, Beirut, and there is a paper out of Japan that suggests the rigidity of pelvic fixation may accelerate hip joint space loss. And I kind of looked at that and was troubled by it. So what we have done is to go look at our adult spinal deformity population to say, what is the prevalence of total joint arthroplasty? And so in our population, it's 26%, which is 8 times higher than the best published literature study by Kremers out of Mayo Clinic looking at age-related prevalence of total joint arthroplasty. And I've looked at, and I'm in the process of looking at other cohorts. I hope I can get Keith Bridwell's ASLS cohort to look at and say, you know, all right, what is that? And so I think that our adult deformity patients have a higher prevalence of wearing out joints, and that we're trying to put that story out. Now, what I can't tell you is if we fuse their spines, does that accelerate their already increased propensity for needing joint replacement or not? But I think it's a lot of the patient diathesis as much as it is the biomechanical change.
Thank you. I live with one. Nasrin just had a total hip after the spine fusion.
Well, and she probably feels that the hip was easier to live through than the
Absolutely.
spine.
She gave up on the spine surgeon and said, I'm going to hip surgeon. I said, you're making the right decision. They're happy with the results.
All right. And then I saw that Jens Chapman put something in the chat about what about Bertolatti syndrome? Great question. I think the challenge of differentiating is the pain from the SI joint or the transitional segment is a real deal. I also think that if you're not used to looking at what we choose to call a dysmorphic sacrum and you don't use navigation, you're at risk of putting an implant in the wrong place in someone who has a transitional segment. So my workup for that is the standard workup for the SI joint, and then I will get CT guided injections into the transitional segment. I've actually had 2 patients where their Bertolotti's, the joint or false joint part of it was anterior based and it couldn't be accessed from posterior. And I got one of my very good radiologists to come along with an anterior injection along the iliacus muscle, delivering a needle to the anterior pseudoarticulation. And so I've seen reports of people who've been successful in resecting the pseudoarthrosis and restoring motion. The folks from Cleveland Clinic and some other places. When I've tried that, I've been genuinely unsuccessful. And so if I think their Bertolotti's is part of it, then I will go ahead and fuse that segment, just because I don't think that those facet joints are normal and are used to carrying load in a normal way. I don't have strong evidence base to support that statement, but that's been my clinical experience.
Well, we're a few minutes past the hour. Dr. Pauly, that was awesome. I know it's going to be helpful for our fellows. Certainly, it was helpful for me in learning more about the SI joint. So really grateful to you for your time. On the back end, I just want to make a quick plug for the Bridging the Gap conference, which will be in July here in lovely San Diego. It's a great meeting, not just looking outwards towards our patients, but also looking inwards towards us and the gaps that we still have to fill in our field. So everyone have an excellent weekend. Again, Dr. Pauly, thank you so much, and we'll talk soon.
Thank you, David.
Thank you, David.
Thanks, Dr. Pauly.
All right.
We'll see you soon.
Thank
All
you.
right. Bye.